Radiographic quality assurance. You take proper quality radiographs, else it is not going to be of diagnostic purpose. When it is not of diagnostic purpose, you tend to repeat the radiograph and eventually you are going to increase the exposure of the patient. Your question can be, the following are weekly schedules except, the following are monthly schedules except. Okay. What do you do daily? These are the following daily schedules. This is there in white and fur as a tabular column. Yes? Okay. And this is reference radiograph. You take fresh films out of a box, fresh developer solution, fresh fixer solution. You may develop a film and then you keep that as a comparing film on top, and every day that you are taking a radiograph, you are supposed to compare it with that first radiograph. You are checking for the quality of your processing solutions and the quality of your stocked films. Step wedge technique is made of your aluminum, your lead foils which is present inside your IOPA film. You remove all lead foils and take about 5 foils and staple it together and start cutting it. You have cut here 1/4, 2/4, 3/4 and 4/4. So you have a step wedge and you place that step wedge on a IOPA film and shoot. When you shoot, you will have, based on the varying densities, you are going to have a IOPA film developed, and you will have to compare the reference film, this as the reference film, and then you will have to compare your daily films on that. Okay, this is your step wedge technique made with lead films. If it's going to be very dark, the daily radiograph which you are making, if it's going to be very dark, it means that your solutions are too thick. Okay, if it's going to be too light, means your solutions have depleted. So ideally it should be somewhere between the third and the fourth. Alright. Entering findings in a retake log. Something goes wrong, you retake, you will have to enter the finding on the retake log so that you will not make that mistake again. Replenishment of processing solution, that was an MCQ question. How much do you replenish developer? 8 gallons? 8 gallons? No. You are mixing up 2 units. 8 ounces per gallon. How much is 1 gallon? That was also an MCQ question. How much is for automatic processing? That is different from manual processing. That was also an MCQ question. 1 gallon is 3.6 liters. Okay, so 8 ounces per 3.6 liters and 8 ounces per 1 liter, 1 gallon also means the same. That is one question that can confuse you. It is same for developer and fixer in manual processing. In your automatic processing, 4 ounces for developer and 6 ounces for fixer. Okay? I think it keeps going on the paper all the time. Yeah, I remember you guys noting this last time during MCQ session. A bit of recap will help. These are MCQ questions. This is again an MCQ question. Processing temperature. When you are using temp temperature method, this should be the ideal temperature for you to use the processing solutions. What are the methods of development? Methods of developing. You broadly classify it into? Sorry? And? Manual and automatic. Under manual? Visual method and time temperature method. So under time temperature method, these are your measurements, and this is an MCQ question. Okay. These are your weekly tasks. Okay. Replacing the solutions, cleaning equipments, and retake logs. monthly. How do you do safe flight testing? What's the name of the test? Benny test or your coin test. Okay. What are the parts of your intensifying screen? Base, phosphor layer, reflecting layer. Reflecting layer is between the two. You will have to go back a bit on the basics, please. You know how the penny test is done. You place a penny on your film and keep it on the safe light for about 2 to 3 minutes, and then you develop that film. If it's going to have a shadow like that, then it means improper safe lighting, and then if there is no shadow and the film is clear, then it is a proper safe lighting. Okay. Now see the layers. You have a phosphor layer, reflecting layer, protective layer, and a plastic base. And the same thing will be on the other side. Okay. You have two sides for that. It's been sandwiched. So you're going to clean the intensifying screen. If it's not clean, you will have those images on your final image. You will have to rotate the film stock, like you take the old ones first, finish it off, and then take the new ones. Films have expiry date. It can deteriorate with time. Okay. Do I have to stop? He's taken off the camera. What is the normal aluminium filtration for a machine less than 70 kVp? Less than 70 kVp. Point 2. Apdi filtration illa. 2 mm is not for a machine less than 70 kV. Answer is there in this book. It's not on the head. That's the problem. So a machine more than 70 kVp, it is 2.5 mm. For a machine less than 70 kVp, it is 1.5 mm. We'll have MCQ test one day. That was about radiation, this thing. Not much of MCQs from that. Alright. What are the types of films you know in IOPA film? Types of IOPA film? Size which, okay, 0, 1, 2. Then apart from the size, what other you can tell? Size on approve? Speed, DEF. Then one more. Based on emulsion. What emulsion image are you using now? Do you know that you are using double emulsion IOPA films? You have single emulsion, double emulsion. What we are using currently is double emulsion. It gives you better images. Okay. Adu illama other types. I want more. You have barrier, with barrier, without barrier. This is without barrier, your regular IOPA emission. This is with barrier, it comes along with the cover. This is not available here, but otherwise it is there. This is with barrier, without barrier. So you have this many types of IOPAs. Apart from size, apart from your speed, right? Then your with barrier, without barrier, emulsions. That was your infection control. Nothing right in that. Definition of dental caries. Radiolucent. Why is dental caries appearing radiolucent? Why is it appearing radio opaque? Normal tooth appearing radio opaque, but your dental caries is appearing radiolucent because demineralization. How much of mineral should be lost so as to appear radiolucent? No, your incipient caries are not visible on radiograph. So how much of mineral loss should happen for it to appear on a radiograph? You just said something. 30%. 30% of mineral loss should happen for it to appear as even as a small change on your radiograph. There is something called as subtraction radiography. Yes. For that 5% of mineral loss is sufficient to produce a defect. Okay. That is an MCQ question. There is a range for mineral loss, 30 to 50%. So they give you 30% or 50%, both the answers are correct. Types of caries, okay. Classification, this is mandatory to know, D1, D2, D4. This is radiographic classification of dental caries, not clinical classification. Less than halfway thickness of enamel, more than halfway of enamel, through the DEJ, involving the pulp. So based on this, this is radiographic classification D1, D2, D3 and D4. And if it's going to be like that, radiographically you cannot see an incipient caries. Moderate means it will extend to dentine and you will have a thin radiolucent line, and severe means it is going to involve as a large radiolucency, it will be seen as a cavitation. Your radiographic appearance for all this. How will you differentiate between an acrylic restoration and a DC? Acrylic fillings and a DC, how will you differentiate? Silicate fillings and acrylic fillings and DC. You understood my question? How will they appear on radiograph? Normala? Cherry. How will amalgam appear on radiograph? Radio opaque. Your acrylic silicate restorations? Radiolucent. Now how will you differentiate between that and a DC? Definite margins. Okay? And clinically you will have to inspect. Basically both are radiolucent, so it is hard to differentiate. How will you distinguish between a DC which is buccal or lingual? DC. You can't differentiate whether the restoration is on buccal or lingual. Slob rule is only for object localization. That's actually a confusing question. Okay. What is cervical burnout? How will you differentiate between cervical burnout and proximal caries? Cervical burnout will be triangular in shape. Okay, it will have a definitive enamel cap, it will have a definitive cementum. When you inspect clinically also, you will not see much of a visible caries. But generally proximal caries you are not able to see on a clinical examination. That is why you are going for a radiograph. When you see on a radiograph, you have a scooped out appearance, you have a bit of loss of enamel and a bit of loss of your cementum, and it is not in a definitive triangular shape, then you consider it as a proximal caries. Proximal caries generally it will be in one or two teeth. If you are going to see cervical burnout, it will be in all the teeth. So that's how you differentiate between a proximal caries and cervical burnout. Where do you see apple core appearance? That was an MCQ question I gave you. Apple core appearance. Radiation induced caries, it will give you an apple core appearance. Nothing, you bite an apple, you see an indentation. So that kind of an appearance will have in a radiation induced caries. And radiation induced caries, you will have superficial lesions, you will have involving cementum dentine, and you will have lesions which is causing the entire crown to become black. Why did induced caries happen? What is the relation between radiation and caries? Xerostomia. Your saliva goes down, so which means your salivary pH has gone down, buffering action is lost, following which you are having dental caries. When you can see recurrent caries there, mild radiolucency below a restoration, that is your recurrent caries. Your rampant caries. MAC band defects, what is it? When you are having nice heavily restored tooth, you will tend to see a MAC band defect. It is nothing but when a dark shade meets a light shade, the dark area will appear darker and the light area will appear lighter. Normally it is not that dark, normally it is not that light, but when too many restorations are close together, it will appear brighter than normal. And if it is going to be darker than normal, if you are going to suspect a dental caries. You understood? Normally your pulp is going to be dark only, but it will be even darker. Normally your dentin will be much darker than that of your enamel, but it is going to be even darker, which will it will subject you to a question whether it is a dental caries or not. So you see there, so many teeth are heavily restored. They have given an arrow mark, because when the dark area is meeting another area, lighter area, you are having an illusion as though there is a dental caries there, but it is not a dental caries. It is an optical illusion. So the MCQ here can be uniformly dark shade means a uniform light shade. So the dark shade appear darker or dark shade appear lighter. The light shade appear lighter or the light shade appear darker. So they will confuse you with that. The last two lines is important. Dark area will appear darker and light area will appear even more lighter. So be clear on that line alone. In the entire dental caries chapter, you will have only two things important. One is your cervical burnout and the second thing is your MAC band defect. And MCQs can be on these two questions, or it will be on how an acrylic restoration will appear on a radiograph. Radiolucent, radio opaque, both A and B, neither A nor B. So answer is actually only radiolucent. Okay. What are the clinical conditions where you can have a non-vital tooth? The etiology for non-vital tooth? Trauma, fractures. Okay. Then caries. Then adala idile vandrum. Cyst tumor la you will have external root resorption. Okay. So external root resorption is your answer. Then two more. Internal root resorption. Okay. Which is that lesion where you have borderline or variety? Some disease which has a borderline or variety. There are three types in that disease. Three stages or types in that disease, of which one stage is borderline. Leprosy. So adula enga vandu non-vital teeth varum. What is lepra teeth? Burkitt's leprosy and the chapter left. They tell you, right? The nerve to the, what's the nerve to the incisors? Incisive nerve that gets cut off. Your incisors are affected. Anterior part of your maxilla is affected. Your teeth will flare. Not like that. This one small paragraph. But they have not mentioned that name called lepra teeth. That is one rare cause of non-vital teeth. Apart from that, what is Turner's hypoplasia? When an infection in your primary teeth hits on the permanent teeth, infection or trauma, you will have a Turner's hypoplasia of your permanent teeth. When that goes severe, again it will become non-vital. So as and when your tooth is developing only, you will have a non-vital tooth. So this many causes for non-vital tooth. There are 5 causes for non-vital tooth. Dental caries, trauma, your internal resorption, external resorption, lepra teeth. Periapical radiolucencies. How do you differentiate between an acute abscess and a chronic abscess radiographically? Okay. In acute abscess, you will have only widening of periodontal ligament space. In chronic abscess, you will have a solid bone loss. Just the widening of periodontal ligament space will be called as an abscess. But it is acute, so that much of bone change is not happening. Chronic is there for a long time, so bony changes are happening. That is when you will have a periapical radiolucency. So just because you don't see a periapical radiolucency, you cannot say it is not an abscess. You touch that patient's, you palpate the patients in the periapical area, patient says pain, that is abscess. If you don't see a swelling also, it is okay. You palpate that area, you see a patient elicits pain, you call it abscess. Radiographically, you see periodontal ligament space widening, again it's called as an abscess. Differentiating between abscess and granuloma. That's all. Granuloma is less than 1 centimeter. Okay. Radicular cyst and periapical granuloma. Sclerotic border on the periphery. Well-defined radiolucency will be there in radicular cyst. Radiographic appearances of osteomyelitis. Sorry? Moth-eaten appearance. Onion skin periosteal reaction. Or it is either a normal periosteal reaction in acute or chronic osteomyelitis, or it is the only reaction in your Gary's osteomyelitis. Okay, then one more. What is the radiographic appearance of your chronic diffuse sclerosing osteomyelitis? That is what you have left out. Cotton wool appearance. Cotton wool appearance is seen in chronic diffuse sclerosing osteomyelitis. Okay. When do you see a scar? When do you see a surgical defect? Periapical scar and periapical surgical defect. When does that happen? See, you do an epicoectomy and the lesion heals only to some extent and then it stops healing. You have a defect there. That is your post-surgical defect. Okay. You do, there is a abscess. You do RCT. Abscess is supposed to drain, but it drains only to a certain extent and then still a radiolucency remains. That is your periapical scar. Okay. Instead of bone forming, fibrous tissue goes and falls there. Okay. It's not proper bone formation happening. So that is your periapical scar. Clear? You see that difference? First image you only see a periapical widening, periodontal ligament widening. So that is your acute. Whereas in case of chronic you see a well-defined, not well-defined, but you see a huge radiolucency. That is your chronic. Radicular cyst, you have a well-defined sclerotic border and it can go up to 1.6 centimeter in size. That is an MCQ question. And the common site of your radicular cyst is incisors. Maxillary incisor is the most common site of your radicular cyst. Osteomyelitis is common in the mandible than that of maxilla. Why? Okay, and maxilla? Maxilla bone is porous and it has got very rich blood supply, so the chance of osteomyelitis is low. Difference between condensing osteitis and idiopathic osteosclerosis. What is condensing osteitis? Normally, when you are having an irritation, your bone will respond by resorption. But if your bone is going to respond by bone deposition, then it is condensing osteitis. You have dental caries, pulpal involvement, your periapical tissues are getting irritated, but there is bone deposition rather than resorption. That is your condensing osteitis. Idiopathic osteosclerosis has no reason why it is happening. It will not touch the tooth. Somewhere in the bone, you will have bone deposition. Excessive bone deposition lying loose in the bone, nowhere in contact with your teeth. That is your idiopathic osteosclerosis, common in old age and females. So these are various radiographic appearances of your restorations. This is where I told you your acrylic silicate restorations are going to appear radiolucent. That is of significance. That was dental caries chapter. Periodontal disease, you don't have much of findings to say. Just horizontal bone loss, vertical bone loss, percussion involvement. These are the three terminologies in this entire chapter. So, and you know this terminologies from your perio textbook for periodontal involvement, crestal irregularities. You have any idea of that? 1 wall defect, 2 wall defect, 3 wall defects. So that is appearing on radiograph. That's all. You cannot identify the 1 wall defect, 2 wall defect, 3 wall defect on a radiograph. All right. Triangulation, funneling, all these are your perio terminologies. Interproximal crater is also a perio terminology. All this is there in your perio textbook. This is important. If you are going to have 2 to 3 mm of your tooth visibility from your alveolar bone, it is considered normal. Beyond which it goes, bone loss. You understood? From your CEJ, if your bone height is just 2 to 3 mm distance, then it is normal bone. If it is beyond that, it is bone loss. This is an MCQ question. If you read the chapter on perio bone loss and all that, this chapter is covered. Terminologies in periodontics, your crater, interproximal crater, your angular bone loss, all this will come. What kind of bone loss is seen in aggressive periodontitis? Angular bone loss. And what is the bacteria involved in aggressive periodontitis? Comitants. What is the bacteria involved in chronic periodontitis? Multiple. Okay. And kind of bone loss in your chronic periodontitis? Horizontal bone loss. What is the teeth affected in aggressive periodontitis? Incisor and first molar. Why? First teeth to erupt in the oral cavity. When do you call a teeth to be localized periodontitis? When do you call it to be a generalized periodontitis? Teeth surface. So how many teeth will come? Have you ever calculated? 7. Okay, 7 and less than 7 is considered as localized, and more than 7 is considered as generalized. So be very careful. It is 30% of tooth surfaces. It is tooth surface, not teeth. Okay? These are the common questions in perio, but otherwise nothing in that chapter. You will know the parts of the implant? No? You will know? Okay. But what I am concerned about is this. What X-rays to be taken for what implant and at what stage. Just remember, read only the applications for each imaging technique. SMEA, single implant, multiple implant, adu mattu padichukonga. Seringla. Advantage, disadvantage is not required. Just for which IOPA technique, for which kind of implants. This alone you by heart. Okay, this is the MCQ part of it. And prosthetics, you have something called as type of bone loss. Edentulous panel, you have bone loss. So the types of bone loss you will have. You know what are the stages or types? Knife edged, rounded. The first diagram, it explains it all. So this is what I told you about CBCT. You are going to see the height, width, proximity to the adjacent structures and the nerve tracing part. So you do all this, you can place an implant. Apart from this, axial inclination of your implant. When one of this goes wrong, you will have this. This was one of your MCQ questions. Remember? Peri-implantitis was your MCQ question. So they can ask you any of the radiographic appearance and ask what does it mean. or they can ask you any of your clinical implications and ask you for the radiographic appearance of the same. Say for example, like thin radiolucent line along the entire outline of implant means peri-implantitis. It is suggestive of the failure of implant to osseointegrate. So like that each of it will have a significance. This is important. What is the time duration of each stage of your implant? Say like treatment planning, I am starting 1 month before itself, and then I am calling the patient and placing the surgical placement of implant is the first stage, that is considered as month 0. Okay. Then healing phase I am giving about 3 months, and then remodeling bone happens between 4 to 12 months. This is all ideal placements, okay, but this is not what we practice, but these are all ideal placements for textbook purpose. And then you maintain without any problem for 13 months or more, and then but however complications can occur at any time. The important part for us is what are all the radiographs you will prescribe at each visit. That is an MCQ question. This is a cutout from your white and Faro. All this is from 6th edition. I am not sure if it is available in the 5th edition. Your difference between 5th and 6th is, in 5th edition they would have given you TMJ techniques and your transcranial, transorbital, transsagittal. But in your, like this each chapter they would have given you techniques of TMJ imaging, techniques of sinus imaging. That is your 5th edition. In 6th edition they completely eliminated the techniques, but they have added your TMJ diseases, radiographic appearances of TMJ diseases, radiographic appearances of sinus diseases, radiographic appearance of maxillofacial trauma. That is the difference between your 5th and 6th edition. Okay. Yeah, and this last line is an MCQ. Success rate of 85% at the end of 5 years and success rate of 80% at the end year. This is the minimum criteria for success of an implant. This when percentage, numbers, values, all this comes, they are definitely MCQ questions. And how much amount bone loss will happen if you are going to place an implant, but how much of bone loss is permissible? It is 0.2 mm. Whatever implant you place, however good you place it, some amount of bone loss is invincible. You can't stop it. But there is only a limit beyond which it should not happen. Beyond which it happens, it will not osseointegrate, you will have peri-implantitis. And if it is going to be less than 0.2 mm, then it is considered as normal. That is again an MCQ question. This chapter, you read only this. Don't go anything inside. The major questions will be, what is the canthomeatal angulation? What is the position of patient perpendicular to the plane, parallel to the plane? Only this will be the questions. Okay. Apart from this, I will tell you what all questions. The second diagram, SMV. What is the contraindication of SMV? Cervical injury. That is one. What is the variation of SMV? Jug handle view. How much of exposure time should be there for jug handle view? 1/3 of exposure factors of SMV. Okay. And apart from this, what are the indications for lateral ceph? Orthodontic purpose? That is a major indication. How come you will get a soft tissue profile in lateral ceph? What is that? You will place an aluminium wedge filter which will selectively attenuate your X-ray beam, and that is why you are having a soft tissue profile. This is one extra question. Possible extra questions in extraoral view is only this much. You remember angulations in everything. Okay. And this is your TMJ views, transcranial, transorbital and transpharyngeal. And they have given other names for your other names for all of this. It's there in your textbook. McQueen's view, Zimmer's projection, Palmer's projection, all is there. They will be your standard MCQ questions. And which surface of TMJ is seen in which view? Like if you are going to take your transorbital view, which surface will be seen? Anteroposterior. In transcranial, you are going to see the lateral view. In transpharyngeal, you are going to see the medial view of condyle. This is the maximum possible MCQs that they can ask in this. And if you are going to say Waters view, I am going to see my paranasal sinuses. If you are going to ask for submental vertex view, I am going to see my base of skull. If I am going to ask for jug handle view, I will be see my zygomatic arch alone. And then if you are going to ask for reverse Townes view, it is for my TMJ. If it is going to be PSF, it is just for your normal skeletal profile. It can be used for your maxillofacial trauma cases. If it is going to be oblique lateral of body or ramus, it is to see any impactions, fractures, cystine tumors, extents, that is it. So, maximum number of question is only this much in this, you remember this column, you will be fine. Okay. Panoramic radiography. The last two lines were your MCQs, do you remember? Numata and Patiro, the inventors of your OPG. Arjo Patiro is your father of panoramic radiography. You could probably put a small handbook, authors, years and appearances, normal values, all this can be made as a small handbook. These are the things which are common for MCQs and the things which commonly tend to forget. You would have read it, but it will not strike you at that point of time. And the exposure doses, they are also important MCQs. If you are going to use a rare earth screen, it is 0.007 microsieverts. And if it's going to be your millisieverts, sorry, that's millisieverts. And if you're going to use calcium tungstate screens, you're having 0.01 millisieverts. That is an MCQ time. Indications, advantage, disadvantage, you'll be familiar with. What's the principle behind OPG? What principle does it work under? Image layer, focal trough. That is the basic principle behind OPG. These will be the possible questions. The other name for focal trough, image layer. What is image layer? It's a 3D curvilinear image layer, imaginary concept. It's an imaginary concept where your 3-dimensional jaw is being flattened out into a 2-dimensional image. Okay, so this is a basic principle. And then you'll have questions on rotation center. How many rotation centers are maximum possible? Minimum possible? Minimum is 1, maximum is n number. What we are using is n number. Okay, you have 1 rotation center, 2 rotation center, 3 rotation center. Now you are having maximum number of rotation centers. Rotation center is nothing but the point or a pivot around which your X-ray film and your source is moving around the patient. That is your rotation center. Okay, you having doubts? Okay. And you have a narrow slit which is lead lined, and through that slit only your X-ray beam passes out. And if you are going to say in case of your IOPA machine, what do you have? You have a collimator. So the same collimator, the collimator is rectangular or circular. Here it is like a long slit. That's all. So this is about your rotation center. Okay, 1, 2, 3. This is your image layer or focal trough or focal corridor. These are the various names for your image layer. And the objects which is going to be outside the image layer is going to be magnified. Objects within the image layer will appear as proper image. That is a basic concept. The size of your OPG cassette? Size of IOPA film, occlusal film, bite wing film, your OPG films, your CT films, all these are MCQ questions. Yeah? Sorry? 5 into 6 inches in centimeters. This is an MCQ question, 70 to 100 kVp, 4 to 12 MA and 18 seconds. It is 8 into 10 centimeters. Okay, each of this has an MCQ. If the Frankfurt plane is not parallel to the floor, what will be the radiographic artifact or error? Frankfurt plane, if it is not parallel, say suppose it is the patient's head is tipped down, then what will be the error? You understood my question? No, something to do with the smile. Head is tipped down. It's an exaggerated smile. If the head is tipped up, then it is a reverse smile. You could actually position yourself and then see. Alright. Second thing, mid-sagittal plane is perpendicular to the floor. Say it is not perpendicular to the floor. It is tilted to one side. Then what happens? The side towards the X-ray source. Okay. If that side is so close, that side is going to appear small. The side opposite to the X-ray source is going to appear magnified. Okay. So that is with your mid-sagittal plane. Patient is asked to remain still during the exposure. Patient is not still. He has moved. Then what will happen? Blurring will happen. Okay, this is one. If the patient is going to be fat, okay, and when you are making the patient sit, he is not coming within that L beam, what will happen? There will be an impedance, right? It will not move around the patient. So wherever it started to stop, that area will appear black. Okay? Right. Patient is asked to sit straight with the back erect, not sitting straight, slumping and sitting. Then what will happen? Normally you will see a spine shadow. When this is happening, you will be completely white, very, very white. Spine shadow will be there in a normal OPG. But when patient is not going to sit erect, it will appear even more prominent. Alright. What else? Patient is asked to bite on the plastic or disposable bite block. When that is not happening, what will happen? Patient is not biting. Then you can't assess the TMJ. TMJ will be, smudged. That area will appear smudged. One more line I have not written. Patient will be asked to put the tongue on the palate. That is actually the resting position. If you unknowingly, unconsciously check, when you are normally sitting like this, your tongue will be on the palate. It will not be on the floor. So when that does not happen, when we are intentionally asking a patient to sit erect, the tongue kind of falls back. So we will have to specifically instruct the patient to put the tongue on the palate. Why so? If that does. Shadow of the, what is palatoglossal space? Palatoglossal arch irukkulle, that will appear as one radiolucent line across your maxilla. So maxillary teeth oda apex ella cut aayidum. You will have a dark line across like that if the patient's tongue is not positioned on the palate. Apart from this, you have ghost image. Okay, my right side earring will appear on the left side and it will appear at a higher place and it will appear magnified. This is one MCQ. Okay, ghost image is on the same side as that of your original image. Ghost image is on the smaller size than that of your original image. Ghost side is at a lower level than that of your original image. All these are wrong answers. Okay, the right answer is, my right side earring is there, it is appearing on my left side, but it will appear at a higher side and it will appear as a larger size. Alright? Okay. That is your ghost image. So, larger, indistinct, higher than the actual counterpart, ghost image. Yeah, if your teeth is going to be too anterior, I told you biting on the bite block. If it's too anterior, not on the bite block, but too anterior to the bite block, then it will all be elongated, thin. If it's too posterior to the bite block and not on that wedge, then it will all be broadened out, it will be flat, like this. Exactly, they should bite on that black line. If they are not biting on the black line, then this happens. Teeth too anterior or teeth too posterior. All these errors can be your MCQ questions. Your exaggerated smile, your reverse smile. Lead apron artifact. You are not supposed to wear a thyroid collar for OPG. For the rest you can wear for the patient. Okay, the patient should not wear a thyroid collar for taking an OPG. You know, you will get till the hyoid bone. But when you are going to obstruct the hyoid bone, that is going to be seen as a radiopaque artifact. Hello? Yes? Can I talk in 5 minutes? Thank you. Can I talk after 10 minutes? Palatoglossal airspace. Okay. Can you see that radiolucent line across? Patient is not placing the tongue on the palate. This is static electricity. It is seen in any kind of extraoral radiography. If you're going to open the cassette all of a sudden, you will have this. Static electricity, tell me in terms of physics. Where do you see static electricity in physics? You brush your hair 10 times and then pull on your skin hair, it will all stand up. You are creating a static electricity. Same principle on this. Okay, done for the day?